So welcome to Cindy Harvey. Cindy Harvey has been teaching with the North American School of Podology for, I think, as many years as I have been. She's been with us for a good long time. She has so much enthusiasm and so much passion, and she really knows the biomechanics. She knows about feet. She knows, just it's things that we don't even take into consideration, but just a certain way that we walk or all different sorts of things. It affects our gait, which then affects where we have calluses, dry skin, etc. And we think, oh, there's nothing that we can do. There absolutely is. So, I'd love to extend a warm welcome to Cindy, and I'm going to hand the floor over to Cindy. And again, Cindy, thank you so much for being here and doing this presentation this evening.
Thank you very much, Vicki, and welcome everybody. I'm so glad that you could join us because I feel that this is a way for you to expand your knowledge and expand your business by separating yourself a little bit from the standard pedicurist, because it gives you more insight and more valuable tools to be able to help the feet walk better. I currently, just to give you a bit of my background, I currently operate a clinic in a Good Life Fitness Club, which of course has been impacted by the COVID. However, we are getting ready to reopen again. And what my clinic specializes in is watching people walk. So what biomechanics really broken down means, it's watching people walk and watching how they distribute weight on the feet. So I like to give you a bit of insight as to what is a good gait, and then therefore what would consist of a poor gait or a gait that we could help people with. And there's many tools that we can use without going to something that's custom made for the foot, of course incurring a lot more expense. I've been working now in the pedorthist field for over 20 years. A pedorthist is licensed to assess the way you walk and cast your feet, and therefore make or manufacture a custom-made orthotic. But we've also come to realize that not everybody needs custom-made, and there's lots that we can do to control the way they walk, or at least help them. So let's start with our first slide, and I'll just let Vicki control that, I think.
No, Cindy, you get to control your slide. Use the arrow key.
Arrow. Right, sorry.
That's okay. There we go. Perfect.
Okay, so function of the foot. Basically, I wanted to make sure that you understood the foot is to aid us in ambulation. So its main responsibility is to propel our body forward. That propulsion comes from the arch of our foot. So if our arch is collapsed or not working properly, we are not going to get that forward propulsion. And that is the main function of our foot. Also, obviously, to support our body. Hence the reason why we walk on 2 feet and not all 4s. 2 main functions of the foot. So not to be confused with the first slide. First function is support or static demands. This just means standing still. So we would assess a patient standing as well as walking, because standing, oftentimes that's when we see them putting more weight on one foot rather than the other, not balancing equally 50-50. Propulsion is the other main function. So this is considered a dynamic demand, or a demand that the body is moving. So rather than standing still, it now involves some kind of ambulation, walking, running, etc. anatomy of the foot, and this is just briefly, we have 26 bones in the foot, 33 joints, 107 tendons and ligaments. So it's very easy to see when we strain a tendon or a ligament, how it affects the way we walk. And it's very common because there's so many of them. Who ever thought 107 tendons and ligaments in one body part? 18 muscles in a foot. So it's quite an extensive medical production to walk. So many muscles and joints have to be in uniform and doing the same thing. They all have a responsibility. Bones, we know, are connected to each other by ligaments. So when we sprain ligaments, we know that that's going to affect the way the bone is moving. Plantar fascia. So again, another buzzword that you will hear throughout my conversation, because this is probably something that is the most common injury in feet. So when people tell you they have foot pain, this typically is what it is, plantar fasciitis. We attach itis just to indicate inflammation. That fascia is like a covering on the tendon. So if you think of a sausage and you think of the covering on that sausage that holds it all together, that's basically what your fascia is doing. It's hugging that muscle and allowing it to stretch or extract and contract as it needs to keep the bones in place. All righty. So a couple of little pictures for you there that shows you the different bones in the foot. I believe that you would have received the picture on the right in your workbooks that you've had in level 1. The picture on the left, however, I wanted to include to show you the different position the bones take when you are wearing a high heel shoe. So you can see how much pressure we put on the sesamoid and the first metatarsal heads and rays when we put all of our weight forward on the forefoot. So it's just an interesting observation in an x-ray that shows you the placement of the bones. So I thought that would be help you in convincing some of our ladies that they shouldn't be wearing high heels 7 days a week. Yes, it's okay once in a while. I'm very forgiving as a podorthist, but I think if they're wearing them daily, it's going to cause severe deformities and pain. So we're going to talk a little bit about those deformities later on. 3 basic types of feet, and I feel it's necessary for you to understand that these are typically feet that we're born with. So structurally, this is the DNA you've inherited. A rectus foot is what the rectus word is Latin for normal. So this is what we would consider to be a normal foot. Structure is normal, meaning the bones are all in alignment and the tendons and ligaments are all in alignment. So a normal foot, and I like you to see it from the bottom, has a lateral wall running along the side of it and an arch that comes into the foot. So you can see that the arch comes in to about the 3rd or 4th web space, okay? Leaving this lateral wall on the foot to help distribute weight. When we're missing or have too much of that, it affects the way we walk. So that arch there is what's responsible for that propulsion forward. When you have a high arch foot or a pes cavus foot, you can see the lateral wall is in fact arched as well, meaning they don't have the same area to distribute that weight, and becomes very unbalanced foot, very wobbly to the ankle. As you can see, this foot would have a tendency to roll either way. In most cases, they have a tendency to roll to the outside, spraining the ankle. There's very little contact with the ground with this foot. You can see that they're a heel toe walker is often how we refer to them, because they're not putting weight in the middle of the foot, therefore not getting the same propulsion. A flat foot or pes planus has no arch or a very low arch. So you can see here, the arch isn't coming into the foot. It's completely flat, which again takes away that propulsion, that movement forward, but it's too much contact with the ground. Oftentimes you will hear this foot coming before you see it because it slaps the ground. Too much contact with the ground, and therefore causes other problems in gait, which we're going to discuss a little later on. So those are your three basic types of feet. Most people will fit into one of those categories. So your rectus foot or your normal foot, we consider it to be a very good shock absorber. So it's designed in such a way to handle us walking on cement and concrete, which is typically what we all work on. Ideally, we want to see a center heel strike, and we want to see the knee track over the foot. So in other words, when we watch someone walk towards us, we want to see that knee staying right over the feet. When you see the knee go to the outside or track to the inside or towards the midline of our body, you will see that the knee is coming out of alignment. And that, in fact, is what leads to knee pain. And that, in fact, is what leads to knee replacements. So you can see that there is a good percentage of the population that is not tracking their knees over the feet. It would also provide a very good distribution of weight with that lateral wall. It's tracking the weight around the arch. It would also indicate then that the hip is moving as it was intended to move. A hip joint is supposed to move forward and backward. If you're putting weight to the outside or the inside of the foot, you're torquing that hip joint with it. Also a good distribution of weight on a rectus foot would end off with the weight coming off the toe or the hallux. In your case, you understand the word hallux. So at the hallux, that would be what we would consider the end of the contact with the ground. So your pes cavus foot, we talked about a little bit about it being a bad distributor of weight. It is a very poor shock absorber, as you can appreciate. When they're going from heel to toe, they're not absorbing. There's not enough time to absorb that shock. I put in here supinated gait because this is typical of how a pes cavus foot walks. It doesn't mean it's set in stone. So you really do have to watch each individual person. But the higher the arch of the foot, the more tendency they have to walk to the outside of the foot, which we would consider to be part and parcel of supination. They would be therefore much more prone to suffer from hip and low back pain. So when your patient says to you that they have hip pain, a lot of times that's coming from the feet because they've put too much weight to the outside of the foot. Because the hip attaches at your lumbar spine or your low back, it often causes low back pain as well. As you can appreciate, this shaped foot is very difficult to find footwear. So it is not an easy foot to fit. Therefore, in many areas of our cities, I find that a lot of the pedicurists do see a lot of pes cavus and pes planus feet, in which case then it may be an opportunity for you to look at footwear as being an extension of your business, or at least being able to give people proper advice how to pick out a good shoe based on the type of foot they have, which we're going to go over towards the end of our presentation. Often you're going to see the pes cavus foot develop severely claw toes and most often hammer toes. They often also develop plantar callousing underneath the metatarsal heads. Because they're a heel-toe walker, they put far too much weight on the met heads and often have severe callousing in this area. Obviously, we don't want to remove all of that callousing because it's growing to protect them. They're putting too much pressure on those bones, and those bones become a pressure point. So they can develop corns. If and when we have diabetics that have this type of foot, we also watch them then for ulcerations under those met heads because of the pressure they're putting there. Okay, so that's your pes cavus foot. Pes planus or low arch foot is often referred to, or the slang definition or term would be a flat foot. We often assign a pronated gait to a flat foot. This again is the classic style of gait that we're going to see a flat foot use, but again, it's not set in stone. You have to watch each individual person because each person will make up their own way of avoiding pain. And this is one of the reasons why gait is so difficult. But again, there are the basic rules that we follow. So why does someone have a flat foot? Often you're going to see that they're born with it. It really was a flat foot. But many cases are going to be because the arch has collapsed. So when a medical doctor assesses you standing, they're going to check your feet with weight. When you see that that foot has collapsed to the floor, the doctor would use the definition pes planus or flat foot. It doesn't necessarily mean you don't have an arch. It just means the arch is not functioning and it has collapsed to the floor. A lot of times that is caused from poor footwear. It's also caused from walking on cement and working on cement all our lives. Feet weren't designed to be in cement, so they were designed to be in dirt, and therefore we strain them. They're very prone, these feet, to arch strain, plantar fasciitis, bunions, arthritis, and several other structural deformities, which we'll discuss a little later on. Most pes planus feet suffer from knee pain. Because the arch collapses, they're tracking, the weight comes to the medial side of the foot, and they're tracking the knee medially, which pulls the knee out of alignment and causes severe pain on the medial side. There will be, in my class, we do teach you how to check for these things, so it does offer you a little more insight as to how to assess a patient. Okay. So very briefly, we're going to talk about the function of the arches. The plantar or longitudinal arch, which is the arch that runs the length of the foot, is responsible for propulsion, like we've discussed. The arches are quite flexible. They absorb the pressure when we step, and then they propel that weight forward. So they absorb the shock of walking, jumping, and they're designed specifically to do that. When we don't have the strength in our feet, they can't function properly either, and you won't have the propulsion here. Arches do affect a person's gait, and they do give the feet the basic shape. So that's your longitudinal plantar arch. There's one more key arch in our foot called the metatarsal or transverse arch. This is the arch that supports the metatarsal heads in the front of the foot or the forefoot. It runs underneath those heads, and it assists us in managing uneven surfaces. So when we walk on beach sand, for example, and then we go from beach sand to grass or from grass to gravel, our foot has to be able to manage those different surfaces. And the metatarsal arch is what allows us to keep balanced but manipulate those surfaces. Now, I thought it was important to talk a little bit about the actions of a foot and the actions that we should be able to make with our foot. So I think, again, if you were examining a patient, you would want to make sure that they have these movements. If they don't, it is very, very understandable that it's going to affect the way they walk. So a dorsiflexion is a movement that we make when we point the foot and bring the toes up towards us. Dorsiflexion is when we bring the toes towards us. So if we start, you'll see my little picture there has a 0 degree. If we start level with the ground, we should be able to bring the toes up 20 degrees greater than the ground. So we should have a 20-degree angle in being able to dorsiflex those toes towards us. A plantar flex would be 50 degrees in a point. So when you start again level, they should be able to point, making a 50-degree movement down. If they're not able to do that, we would term that as being a limited range of motion or a limited, and we could specify exactly what action was limited. So a limited dorsiflexion, a limited plantar flexion, based on what we see. Now, adduction, abduction is one of the most difficult movements to see, but in fact is quite common. When you see adduction, it means that the foot is moving towards the midline of our body. So if you think of the midline as cutting your body in half, if we're moving the foot towards the midline of the body, it would look similar to this movement. I hope you can all see me. So it would be too much weight on the outside of the foot, causing us to curl the foot towards the center of our body. So adduction is adding that forefoot towards us. Abduction, therefore, is the opposite. So abduction is when I move that forefoot away from the midline of my body. So really, truly, that forefoot should track straight. It shouldn't move away. It shouldn't move towards. It's very different not being able to see your faces, that you're understanding some of this. So, inversion, eversion. Inversion, and this again is a very difficult thing for you to see initially, but it's important for you to understand that people do walk with these motions. Inversion is when we see the inside or the bottom of the feet looking in. So again, it would be an action that would have me looking with the weight on the outside of the feet, with the bottom of the feet looking in towards the midline of the body. We should be able to move the foot 35 degrees manually so that we can see we have that kind of movement with the transverse arch doing its job. We should be able to move the foot, the forefoot, from side to side. So an inversion is when we move it towards the bottom of the feet looking in. Eversion then is when the bottom of the feet look out. So if you're walking on the inside of the feet, you're going to cause the bottom of the foot to look out or away from your body. And I know that's a little more advanced, but it definitely is something you're going to see if you're starting to watch people walk. So I did a little diagram here so you can kind of relate to how those actions look when you're watching somebody walk. Okay. Good. So motions of the foot. So now that we understand the foot should have those motions, this is how we're able to determine if they're walking correctly or not. So when we talk about someone walking neutral or ideal, it means that they have a center heel strike with the weight centered over the foot and the weight shifting across the met heads with the toe off at the hallux. If they're not doing that, they have an issue. So a pronated gait is when we see a combination of bad actions. And those actions would include a bad dorsiflexion, a bad eversion, and a bad abduction. Those three actions would be present if we were going to label you a pronator or have a pronated gait. Consequently, a supinated gait is the complete opposite. So you would have a combination of a bad plantar flexion, a bad inversion, and a bad adduction. So when you see those three actions being distorted from neutral or normal, you know there's an issue with the way they're walking. So again, to recap, pronation, typically we see knee pain. Supination, typically we see hip and low back pain. So if your clients are complaining about these things, it may be time to check the way they're walking, or at least check the footwear they're using. So this gives you, again, a little connection with how it looks for a pronated gait with the ankles leaning inward. For a supination gait, the ankles leaning outward. But what I also want to point out there in that diagram is it shows you how they stand on the heel bones. So you see the neutral position. Those ankles are not leaning, meaning they're standing on the centered part of their heel bone, which is exactly correct. When you look at the pronated gait, look at how they're standing on those heels. They're standing on the inside of their heel bone, which leads to heel spurs. It also leads to plantar fasciitis. It also leads to bunion growth. It also leads to pain in the foot overall and the knees. So there's really no question that this person would be in trouble if you were standing like this and walking with the weight on the inside of the feet. You can also see on the supinated slide that the supinated gait would eventually lead to weight on the outside of the heels. And you can see there that that heel bone can also deviate in an exterior rotation. Therefore, you can see that that person is standing on the outside of the heel bone. So again, many things that we can do to correct these things. So gait. Gait is how we describe a pattern of walking or running, but it's basically how we propel movement. It involves balance, but it also involves the coordination of our muscles. There's close to 200 muscles must coordinate just to make a foot take that first step. So it's really quite a unique part of our body. It's the only part of our body that will grow bone after we've done growing, just for your information. So the body is propelled in a rhythm called the gait cycle. The gait cycle is comprised of two individual phases: acceleration or contact with the ground. So we talked a little bit about acceleration. That's that propulsion we referred to, that forward spring. So when we're in contact with the ground, these motions engage, or this part of the foot engages. The other phase of gait is the swing phase. Not a lot of us stop and think that the swing phase obviously affects the way we walk. So when one leg is touching the ground, the other leg is swinging. There are many instances where people have difficulty in the swing phase. Not something you would think of right off, but it definitely is very evident, for example, in a leg length discrepancy. So if you've got one leg shorter than the other, you're definitely not going to be able to swing that leg through the gait as the other leg. The shorter leg would swing much differently from the longer leg. So it would be something that we would watch for. Obviously, it's not as common. Most of the interruptions in this gait cycle is in the contact phase. We also break down the contact phase and the swing phase with stances. These stances help us to individually see where the problem is. So it forces us to really break down where the body's having trouble distributing the weight. When you can break down the contact phase into these 5 stances. So I wanted to talk a little bit about abnormal gait, just so that you get used to watching for it. And I think seeing it, if you just even sit, well, it's not as likely you're going to be sitting in a mall today, but if you just sit and watch people walk, you will see some of these things quite evidently. A unilateral weight-bearing gait. So this is talking about where one side is affected more than the other. So it could be an injury or a sports injury. It could be an accident. It could be temporary. It could be permanent. But it would be a limp. It would be something you would see on one side of the body and not the other. So again, we just refer to it as unilateral, meaning that you're hopping on one side because of pain. Could be many different reasons. Abnormal, limited range of motion. So this is something we talked about with our range of motions. If you're not able to dorsiflex the foot, think about our seniors who don't pick up their feet and do what I call the senior shuffle. So they're really just sliding the feet along the ground to get through the step. When you have a situation where you've lost that dorsiflexion, you're not able to pick up the foot to step properly, which is why our seniors have this, that develop this, it becomes much more of a trip hazard to them because they're not picking up the foot properly. If there's any curb, if there's any stones in the way, oftentimes that will send them flying. So limited range of motion can very much affect the way we walk and can be a safety hazard for our seniors. Angulation, abnormal balance. So unilateral leaning. I see women doing this more than men. When you see someone leaning always to one side, and this can be because of constriction in the muscles, it can be a leg length or bone discrepancy, but it can also be habit, a learned behavior. One foot collapsed more than the other. Maybe they put so much weight on the right, they ended up collapsing just one foot. You would see this unilateral leaning in that case, because a flatter foot would almost present like a leg length discrepancy on one side. Okay. Abnormal muscle contracture. Obviously, when we see diseases like muscular sclerosis, muscular dystrophy, you've got abnormal muscle behavior. And in many, many cases, you're going to see it pulling the foot up into a pes cavus position, but also you can see it turn sideways. Typically, they're pretty serious events in a person's life, but it can also happen because of accidents or injury. We see a lot of muscle contracture as a result of motor vehicle accidents. So those are some of the abnormal gaits that we deal with. But again, some little pictures just to show you what we are referring to when we talk about that knee being over the foot. So again, it's not as detrimental if I see someone who walks and for the slang term, like a duck, where the feet are pointing out. If the hip is rotated, we can't necessarily change that. As long as the knee is tracking over the foot, we're okay. It's when the knee swings in that we're pulling all the ligaments and wearing the knee cartilage, which again is what leads to the knee replacement. So I think that diagram helps you to see what we're watching for. When you can see the person that's walking with the feet straight, the knee is tracking straight. Okay, so sports injuries that are going to affect the way we walk. I thought it was, again, nice to put this into your head to have you think about what may have been or some of the questions that you would ask a patient if they were hopping or limping or maybe using a cane all of a sudden. It could be a sports injury like a fracture. So these are all of the main injuries that you would have a tendency to see that would affect the way a person walks. A fracture is a break. It's a break in a bone. We don't medically use the word break. We didn't break our leg or break our toe. We fractured it. And what the medical profession does is they determine what type of fracture it is. So they would tell you in the report if it was a compound fracture or a splint fracture. So you would be aware of the type of fracture, the patient usually is. A dislocation of a joint, meaning it's completely out of place, is obviously going to affect the way they walk, especially in the foot. Subluxation means the joint is slightly out of place. We used to have this happen in volleyball all the time, where the fingers would behave similar to a toe, in that one of the joints would sublux out of place. And you would often see women on the court literally putting their finger back in place again. So a subluxation is slightly out of place. Not as serious as a dislocation. Still painful, mind you. Sprain. A sprain is a ligament or a tendon. So when we talk about spraining something in the foot, it refers that we've done damage to a ligament or tendon. We never strain a ligament. Thereby, we never sprain a muscle. So medically, we always strain muscles and we sprain ligaments. So again, just a little bit of the medical jargon, so that if you are speaking with any doctors or medical practitioners, they will appreciate you using terminology properly. And obviously, any kind of strain of a muscle or a sprain of a ligament is going to affect the way we walk. More to do with the sprains of ligaments, we also can tear them. We would also determine what type of tear it was, if it was a first, second, or third degree tear. In many cases, it's like a burn. The first, second, and third degree, I mean, is like your burn. So a first degree burn, not as bad as your third degree. Same with a tear. Your third degree ligament tear is considered severe. More than 50% of that ligament tore, which means you should be casted. Many, many people are not casted with this. They're put in a soft bandage or a foot brace that they can take off. And unfortunately, they tend to walk on it too soon. And we always see, residual damage or issues that we have to deal with later on, because most times they weren't casted and the damage is still there. Other common sports injuries would be shin splints. I think you hear a lot about that, pain up the front of the leg. And again, because a lot of us walk on cement, we're going to see this. However, a lot of times when they complain about pain up the front of the leg, it can also be a tendon that is tearing because of a pronated gait, tearing away from the tibia. So there are many things that causes pains up the front of the lower leg, but certainly shin splints is one of them. Other common injuries would be toe injuries. So fractures in the toe. But another thing we're seeing a lot of in Ontario more recently in the last number of years is called turf toe. And turf toe is a condition of the hallux. It will develop rigidity, so it will develop eventually a hallucis rigidus, meaning they can't move the big toe. And this we're seeing because of a lot of the sports being played on artificial turf, meaning that it's grass over top of cement. So really, truly, they're running and playing on cement. And we're starting to see a lot of soccer because we have so much snow in Ontario and it's so cold. We see a lot of the soccer leagues have done an indoor winter kind of venue, and the kids are playing on cement. And we're seeing this turf toe become more prevalent. Plantar fasciitis and heel spurs. Most common foot injury is plantar fasciitis. And that is when we overstretch that plantar tendon in the bottom of the foot, thereby tearing the fascia covering, causing it to inflame. And once it's swollen, it's going to be very, very painful. I've had grown men cry, like weep with their feet in my hands because the pain has been so bad. So it is a very painful condition. If left untreated, meaning left unsupported, plantar fasciitis can and will eventually lead to a heel spur. You're sending a message to the foot to grow more bone so the tendon has less work to do. If that tendon snaps off the foot, you wouldn't be able to move the foot. So where that tendon attaches into the heel bone is where you're pulling the tendon and sending that message. if it grows that heel bone or that heel spur, that becomes 10 times more painful than the plantar fasciitis. You will not even be able to put weight on that heel spur while it's inflamed. Obviously, there are certain things that we would do to help reduce that inflammation, because bottom line, we reduce the inflammation out of our patients' feet, we reduce their pain. Reduce their pain, you're their hero, because there's nothing worse than walking on painful feet. Achilles tendonitis. Again, another very, very common injury that affects the way we walk. The Achilles tendon is the tendon that runs from the back of the heel bone up the back of the leg. It attaches into the bottom of the gastrocnemius muscle, or the calf muscle, the big calf muscle, which is often why people get pain in the calf. And it's not the calf muscle, it's the Achilles tendon. And it's painful at the attachment because they're pulling it. So if you can go back with me to that picture that I showed you of the heel bones going sideways. Can you imagine an Achilles tendon coming down straight? That's the way we should stand. If we're standing like this, 95% of the time, we're pulling that Achilles tendon, thereby weakening that Achilles tendon and thereby setting ourselves up for the opportunity of tearing or putting slight tears, causing inflammation. And really, that's what Achilles tendonitis is. It's inflammation of the Achilles tendon, and can be as a result of the way we're walking. Ligament tears, same thing. When you think about a woman walking in a high heel shoe and she rolls over to the outside or over on the ankle, because of the height difference there, chances are you are going to develop a ligament tear in that kind of a rollout. I mean, you don't even have to be in high heels. Pes cavus feet have a tendency to suffer from these issues much more so, because they do have a tendency to roll out to the outside of their feet. So we see certain injuries with certain foot types. Plantar fasciitis being much more common with a flatter foot type, or at least a rectus foot that's collapsed to that flat foot. Sprains. Obviously, a sprain is going to affect the way we walk. So again, a sprain is inflammation of the tendon or the ligaments. Good. Nature of disease, which should be D-I-S-E-A-S-E. However, I'm sure you'll overlook the odd spelling mistake for me. So nature of disease, we have two types of disease. One, we call them congenital, means we're born with that disease. So an example would be type 1 diabetes. We're born with type 1 diabetes. Sure, it doesn't surface until we're maybe in our teen years, but we're definitely born with the genetic complication that affects diabetes. An acquired disease is something we've acquired after birth. So it could be a disease we picked up in another country. It could be a disease from trauma experienced in some kind of accident. It could be, and I put leg length discrepancy here just because I want you to realize that it is something you could be born with, but it is also something you could acquire. So I've often seen a lot of leg length discrepancies come as a result of car accidents. Oftentimes when one leg is crushed, they have to worry about saving your life. They're not worrying about measuring your legs. So oftentimes when they're cleaning up an injury like that, one leg ends up a bit shorter than the other. So again, it's nice to have that identified so that you can make that up and therefore not have to deal with the pain from walking with that discrepancy. However, you can also be born with it. So there are some diseases that cross over, but most are acquired. Pathology disorders. So now when we talk about disorders of the foot, we talk about things that affect, that our environment affects our structural day-to-day walking. So if our environment affects the way we use our feet, then obviously we would have to ask those questions of our client and find out whether or not they are exposing themselves to the kinds of things that we know contribute to foot problems. So one of those conditions that we see most prevalent is arthritis, inflammation of the joints. Osteoarthritis is your more common form of arthritis. It is due to wear and tear of the joints and typically is weight-bearing joints. So this affects the feet greatly because our feet bear our weight. Other weight-bearing joints, our knees, our hands. Why? Because they pick up things, they hold weight. Our neck, what's it doing? It's holding up our head. So all of these joints are weight-bearing joints, and they will wear out if the friction between those joints is not cushioned by the cartilage. So as we wear our cartilage and that friction becomes more prevalent, the inflammation becomes more prevalent, thereby leading to a case of osteoarthritis. Osteoarthritis is in fact hereditary, or can be. It can also be developed though because of wear and tear in the joints. Many of our athletes will suffer from this later on in life, just from overuse. Rheumatoid arthritis, being one of the worst arthritises, is something that is hereditary. Typically, it attacks all the joints in the body, so not just the hands and feet, but it can attack all the joints. Where osteoarthritis is really specific to those weight-bearing joints. So that's your biggest difference between the two. The rheumatoid arthritis is an inflammation of the synovial membrane. So when it becomes a chronic inflammation, that synovial membrane is what holds the fluid in your joint. So I liken that to the way the joint greases itself. So it keeps itself lubricated and greased so it can move without this friction. Typically in rheumatoid arthritis, that membrane has been attacked or is inflamed and not providing that cushion or that grease that gives it that fluid movement. It does become very debilitating. So you're going to find much more pain with this type of arthritis. But again, there's many things we can do to help that foot. Psoriatic arthritis typically attacks the interphalange joints. So this is interphalange joints are the tiny joints in the fingers and the feet, the toes. Typically it is a joint and tissue disease. So it not only attacks the joint, it attacks the tissue surrounding that joint. So again, making it very difficult for that joint to move freely. Gout is our final form of arthritis. Gout, as you know, it primarily attacks the first metatarsal head, and that's typically where you're going to see it or where you're going to hear your clients complain about it. But that doesn't mean it can't form in other joints, because it can. I have a couple of patients that typically get gout in their knee. I have another couple of clients that get it in their ankle. So it can show up in other places. It's typical in the first metatarsal joint simply because the circulation doesn't bring those crystals back up out of the feet as easy as it does in other joints. So really, gout is a development or a formation of these urate crystals that collect on the joint, and therefore, again, making that lubrication impossible and scratching the joint as you move it. So it creates that friction which is where the pain comes from. Typically, it is associated with food and drink, but we all know that's a little bit of a wives' tale. There's urate crystals found in a lot of different foods, not just red wine and alcohol. However, it is higher in those foods. So the red meats and the red wine have a higher concentration of urate crystals, but so does broccoli. So there you go. It's just whether or not your body breaks down those urate crystals and flushes them out normally. Some people's bodies don't, and they collect on the joint. Okay, plantar fasciitis. So now I'm going to start to show you some items that can help you in dealing with some of these pains that you see your patients are presenting with, or your clients. They've come in to see you for a pedicure, but they're limping all the way to the chair. There are obviously some important questions to ask them. Why are they limping? What did they do? But for the most part, they're not really sure. And in a lot of cases, it's plantar fasciitis. When they have pain in the bottom of the foot, we simply trace the fascia tendon to let us know that it is that tendon that is sore and painful. It would also lead to tight calf muscles, because that Achilles tendon inserts into the heel bone, comes out the other end of the heel bone, called the plantar tendon. So whatever affects the plantar tendon eventually will affect the Achilles tendon. So you're going to find those two scenarios go hand in hand. When they're starting to complain about foot pain, chances are they're going to have pain in the Achilles. And you can check that right at the attachment into the heel bone. A lot of times it's due to insufficient warm-up. I mean, none of us do calisthenics before we go to work, but it's if the feet are cold and we start running, chances are they're not going to respond the way they should. Plantar fasciitis, as I've said, once we palpitate those tendons, you're going to find they're pretty tender, if not severely painful. So one of the things that we're going to be able to show you here is a product called Metalogix. Metalogix manufactures arch lifts. I find these ones to be much more effective than anything that you can find in the drugstore. Dr. Scholl's typically is made of a jelly silicone. And when they step on a Dr. Scholl's, that arch that you see in this product completely collapses, thereby not giving them the kind of support that they really need. These particular items come in small, medium, large. So again, we measure the arch length to make sure that we've got a long enough piece to fit. And these literally have a sticky back. So they peel the paper off and they stick right into the shoe. So you can see that if that was stuck in the shoe, it would support the foot. That could be slid right underneath the insole of the shoe and thereby stay in place, and you wouldn't have to stick it, and therefore you could transfer it from shoe to shoe to shoe, or they could stick it in place if they wear the same shoe at work every day, then fine. So certainly you can see that that would give the foot the kind of support that it would need, which would be better than nothing. Certainly if they can't afford a custom made piece, because obviously the price would be very different. These products are available at a distributor in Ontario. That distributor has agreed to open accounts for any one of our students that would be interested in selling these products in their business, through their business or in the salon. And certainly, I think you'll find that even with doubling the markup, you would find that you're still far more inexpensive than what is being sold in the Shoppers Drug Marts. I shouldn't use store names, in any of the pharmaceutical industries. You're going to find they're much, much cheaper. This is also another type of orthotic or foot support that Metalogics makes and sells. A little bit of a lower arch, but a little bit longer product, so it fits in the shoe a little better. And you can see that there's a bump in the front of it, which would also help support that metatarsal or transverse arch that we talked about, supporting the met heads and not allowing them to collapse to the ground. Often you're going to see that the metatarsal heads should be shaped just like our hand. Often you're going to see they've dropped, and therefore you would see this kind of a drop in the heads to the ground instead of up. So that would be a device on the product that would help support those heads and therefore allow us much more balance on the uneven surfaces. So those are two very inexpensive products that you can recommend to people to try, or even take it upon yourself to sell, which I think would really help to supplement all of our businesses. Certainly, one of the marketing gurus in Toronto indicated that if we're not in retail sales and just performing services, it's going to be very difficult to survive. We really need to broaden our horizons and get into more retail sales as well. Okay, our next issue is a heel spur. So a heel spur is something we talked briefly about with the plantar tendon pulling from that heel bone. It is going to send that message to grow more bone. If the foot grows more bone here at the edge of the heel where that tendon attaches, the tendon can therefore shorten and has less work to do. So therefore, it thinks it's helping you. Unfortunately, that heel spur becomes very painful. One of the solutions that we have in, again, made by the same company, Metalogics, is what they call a heel spur pad. So this would be something that you would be able to put in the shoe, and I'm sorry it's clear silicone, so it's a little difficult to see on the computer. I'm going to put it up against a blue background and see if that helps you see that there is an excavation cut out where the heel bone would sit. So therefore, what this product is doing is taking weight away from the centered part of that heel bone, so that now when that client heel strikes, the silicone is absorbing the shock instead of allowing that to go straight into the bone. It's also distributing the pressure off the heel spur point and allowing the weight to come around the entire heel bone. So these literally can be stuck in any type of pair of shoe. Because it's silicone and pretty flexible, you can trim it to fit a specific shoe, but they do come small, medium, large. So it is pretty easy to make the larges work in all cases, maybe with the exception of young children. They would need a smaller size. But other than that, this has been one of our top sellers because of heel pain, especially for people that are working on concrete. your construction workers, your construction boots are so painful to wear all day. You know, anybody that's in those boots absolutely loves these heel spur pads. So again, another little item, and everything I'm showing you here retails for under $20. So it's not expensive for the customer to entertain being able to do something to help themselves. Haglund's bump. Now, this is something that, again, we don't have any bits and pieces that help with this, but it's good to understand why it develops on the foot, because it's something we can avoid having develop, or if it's caught small enough, it certainly won't continue to cause the patient pain. A Haglund's bump is a bump at the back of the heel bone. So often you will see that it grows out the back. The type of patient that you would see that on most prevalent would be the hockey players. The skate causes it. So it's friction that causes that bump to grow. So if you're rubbing up and down in a shoe because it's not fitting you right, maybe it's too big, you're sliding forward, and therefore you're going up and down in the back of the shoe, that will create or lead to this bone growth. And this bone growth, any bone growth, let's just say, any bone growth on the foot is going to be extremely painful. So this particular one is, in fact, extremely painful. As you can imagine, how do you wear any shoe once it's there? Pretty tough. It becomes so sore. So the nicest way to deal with the Haglund's bump is to avoid growing it in the first place. So if you ever see that starting on a client, I would be looking at their footwear and the way they walked, making sure that footwear is fitting them properly so that they're not creating that friction. I'm going to show you a couple of ways a little later on here, how to tie up a shoe that can help prevent some of this from building up. A little different lace-up system that helps with pronated gait, but also helps control the heel movement and any slippage in shoes. Okay. Hallux valgus, probably one of the most common conditions that you see on the feet, and that is the big toe deviating away from the midline of the body. So again, the midline's the center, and that big toe is now pointing to the left or to the right. It's not staying straight. So it's deviating away from the midline of our body. Many, many contributing factors as to why this develops in people, but the most common reason is excessive pronation. Because a pronated gait walks on the inside of the foot, they toe off extremely heavy on the side of the hallux, contributing to that deviation. Also, when that bunion starts to grow on the first metatarsal head, it also contributes to that toe turning more or deviating at a greater angle. So many contributing factors here, but certainly the way we walk is the biggest one. If we support that arch and make our weight distribute properly on the foot, the bunion will stop growing and the toe will stop turning. So if we haven't done that and we already have a hallux valgus, there are several products that we can use to help train that toe back, but also to help get it out from underneath the other toes or over top of the other toes if it's already crossed. And I think you're going to see that you find that more in neurological conditions of the feet. So they've had some kind of neurological interruption to the foot, thereby causing a deviation, or you're going to find that the deviation is simply due to the way they're walking. one of the things that we can do to help our seniors get those toes out from under is by providing them with what we call a toe separator. So this is one style that's shaped like an hourglass. So it would fit into the web space of the toe to separate those toes. Very comfortable to wear, again, made of silicone. All of these silicone products are easily washed under the tap so they don't disintegrate like what the podiatrist makes of cloth. It will last them, and they can disinfect it. So it's a very hygienic, non-allergenic product. So that's one style of toe separator. The other toe separator is one that's shaped like the web space. And again, I know you're having difficulty seeing that, being that it's clear. So you can see that it's shaped with a curve. That curve is therefore going to fit into the web space. Now, this is a small size. So the one I showed you before is large. We would use that between the big toe and the second digit. This one is for the digiti minimi, or the fifth digit. So the fifth toe, oftentimes you're going to see has rotated and is curling underneath the fourth toe. When that happens, again, they're walking on top of that toe. They need it brought out from under to be more comfortable. The baby toe separator fits very, very nicely to separate that fifth and fourth digit. So again, a really nice way to manage the toes deviating, and certainly much more comfortable. They would put this in, a sock over top of it, and it would stay in place the whole day. Once they get used to wearing it, they don't even notice it's there. They don't feel it. And certainly the biggest complaint I've ever had from anyone is that they drop it and can't find it because they can't see it. So I mark big X's on them so they can't lose them. Mm-hmm. Hallucis rigidus, another condition that again causes great strain in gait. If you cannot flex your toe, and again, maybe you need to tape it so that you can see what it feels like to walk with a toe that doesn't move. But when you cannot flex that big toe, you have to form a type of shuffle in your gait. And this obviously doesn't give you that propulsion to go forward, and it also becomes a trip hazard for our seniors. One of the main reasons for hallucis rigidus that we're seeing, and I talked briefly about it, is this turf toe. These sports being done or played on artificial turf. Osteoarthritis is obviously another contributing factor. Gout is a contributing factor if it's in that first metatarsal head. Surgery, how many bunion surgeries have finished up with a rigid hallux because they've had to pin it or use metal rods in the toe, thereby taking away any movement that would have been possible. Trauma is the other contributing factor here. Where I see it a lot in our practice is steel toe boots. They're constantly sliding in the steel toe. It's not fitting them properly, and they're banging that big toe up against the steel. That repetitive trauma will cause hallucis rigidus. And this is a very painful condition. This is not something that, somebody's going to whine about just for the sake of whining. This is extremely painful. So anybody suffering from this, again, we would support that toe with some cushioning to try and relieve that pain. There isn't really any bits and pieces you could sell for this, but I would pad up underneath the toe so that it was relieving some of the pressure. Okay, Taylor's bunion, also referred to as a bunionette. Now, a bunionette, similar to a bunion, is a bone growth. So the bunion, we know, grows on the first metatarsal head. It grows because of repetitive action and repetitive weight landing on that met head, which means a pronated gait. So when a bunion is constantly being impacted, it's sending a message, the distribution isn't right, grow bone. Give that person more area to distribute that weight. That's why it grows. We've got to take away the reason for that growth by distributing the weight properly. Then it stops. No need for bunion surgery. Taylor's bunionette is the same thing, only it grows on the fifth metatarsal head. So just like a bunion, it's growing for the same reasons, because there's too much weight out there. So typically found in the supinated gait. Anybody that's walking on the outside of the feet has a tendency then to rub that bone. Friction is the only other thing that will cause bone growth. So two things cause bone growth. Constant repetitive pressure, telling the bone, it's not working out. I need more area to put the weight, so it grows. So that's one reason. Pressure from the way we walk, incorrect distribution of weight. The other reason is tight footwear, friction in the shoe. So if we don't look at both the footwear and the way they walk, we're not always solving the problems. We have to consider both aspects. So too tight a shoe is going to cause friction. I know that sounds odd, but it does, because it's too much pressure if it's too tight. And typically across the front of the foot is where we see people wearing their shoes or their footwear too tight. Why? Because retail doesn't offer widths. Not a lot of retail does. Some do, and the ones that are doing it are doing a good job. But the ones that aren't doing it are selling people footwear that is too narrow for their feet. So again, maybe another opportunity for your business to look at carrying some companies, or at least having access to brands that sell the footwear in widths. Okay. Alrighty. Hammer, mallet, and claw toes. So we have three different types of deformities that affect our toes. We break them down by determining what joints they're affecting. So when we talk about a dip joint is a short form or an abbreviated form for the word distal interphalange joint. So distal, we know, means further away from us. So a distal joint would be the joint further away from our body. So it would be the last little joint in the toe or the finger, would be a distal joint. A pip joint is proximal interphalange joint. Proximal being closer to me. Proximal joint being the joint in the toe or the finger that is closest to my body. So when we look at which joint is being affected, it tells us what toe deformity they have. So the hammer toe is the one that's more unique. The hammer toe, lucky me, I inherited them, involves both joints. So both joints are affected. When it says the contracture of the plantar surface, it just means a contracture is towards me and a contracture of the dorsal aspect would look like this. There we go. So you're going to see a toe where this joint and this joint have now been affected. That is a true hammer toe. And lo and behold, we have a product called a hammer toe crest. Now, I apologize for not having one with me. However, I'm going to describe what it looks like. It is a silicone piece that literally sits underneath all the toes. It has a ring on it, which you wear like a ring on a finger. So it slides over the toe and sits literally right underneath those joints. So that when you step down and you put pressure on this hammer toe crest, it literally forces the toes to straighten out and thereby brings the tops of the toes down from the top of the shoe. Because in most cases, what you see here when they have hammer toes is you see them starting to develop sores, calluses, and corns on the top of the joint, which become very painful. You might often wonder, I just spent an hour getting rid of those corns. 3 weeks later, they're back. Why? Because the toes haven't been repositioned in the shoe, or the shoe isn't wide enough and is causing that friction. So we have to look at those two things to try and solve the problem. Otherwise, they're just going to continually develop these kinds of corns. Where that becomes dangerous is if they're diabetic, because diabetics will develop ulcers there. So that's where it becomes a little bit more of a dicey situation. We need to keep watch on that. A mallet toe then, the difference between the three toe deformities, a mallet toe is a deformity of just the dip joint or the distal joint. So it means that just the distal joint is affected. The claw toe, it's the proximal joint. And that's the one you see more often. This is the most common toe deformity in the population, in the general population today. And that's the claw toe. The claw toe, and I'm going to give you a bit of insight here. The claw toe develops because of collapsed arches is one of the main reasons. Because that patient or client learns in order to propel their weight forward, they're not getting that propulsion from the arch. So their body or their foot biomechanics take over and they grip with the toes in the shoe and push themselves forward through the step. So it's a change in biomechanics when they develop these claw toes. They definitely push their weight forward with the toes being gripped. Now, very often we see this also in neurological cases. So not always does it come from pronated gait, but the majority comes from pronated gait. The other portion of them come from neurological conditions and the pes cavus foot. The pes cavus foot is typically born with hammer toes. Now, I've also referred there at the bottom, I see Charcot-Marie tooth disease. So it obviously, I need to explain to you there that the Charcot-Marie tooth, or CMT, is a condition that we would refer to a patient that has had a brain or a back injury. Because any type of brain or back injury is almost always going to affect the way we walk, and it's almost always going to contribute to claw or hammer toes. The toes are going to contract because of the neurological upset in the brain injury or the spinal injury. Okay, so that's when you hear medical people referring to a CMT patient, that's what it means, that they've had a brain or a back injury that has affected the way they walk. Okay, good. Morton's phenomena. And this is something, again, that I think you're going to see very often. A Morton's toe is something we need to check for physically on a patient to determine if it exists. A Morton's neuroma is a nerve pain where sometimes the met heads have dropped and therefore they've moved closer together. When they move closer together, they put pressure on everything that runs between them, which is your nerve and your circulation. So a lot of people will complain to you that they've got numbness and tingling in their toes, like the foot's falling asleep, and yet they're still walking on it. It can't be asleep. It's the pinch in the nerve. So it could be that the met heads have dropped as they stand or walk, and therefore they're pinching the nerves. Once that nerve's inflamed, it's very painful. We call it a Morton's neuroma. There are means that we would teach you to check for these things. That would be more of our hands-on class, but certainly Morton's neuroma you're going to find is pretty common. The Morton's metatarsalgia, again, is also very common. This is an inflammation of the metatarsal heads. I guess it would behoove me to explain why everything is referred to as Morton's. Dr. Thomas Morton was the first surgeon to identify these conditions. So they're named after him. So that's why it's called a Morton's phenomena. So Morton's metatarsalgia is the inflammation of those met heads at the bottom of the forefoot. When those heads become inflamed, they're barely able to put weight on them. So one of the ways that we can help cushion them is, again, another product by Metalogics, made by Metalogics, that's called a metatarsal pad. You can see that it also has a toe separator on it. It's attached. That toe separator would be placed in between the web space, like so on the toe, and you can see that would cause the main part of the pad to line up underneath those met heads. So that's going to provide an extra 3 millimeters of cushioning and shock absorption for those metatarsal heads. What a wonderful thing for a senior who's lost their fat pads. Because really, that's essentially what you're doing, is giving them or making up those fat pads. And again, retails for under $20. Certainly not rocket science on how that would help you increase your business and sales, and certainly a delicious little item in a high heel shoe. Because of where all the weight is on your feet, it certainly helps to absorb the shock from putting the pressure on those met heads. But when someone presents with metatarsalgia or pain there already, within a week, this can help relieve that pain. So really wonderful items to help you try and assess why your patient or why your client is developing these things, and certainly what you can do to help them. So the Morton's toe is a little different issue in that we have to be able to identify that it is a Morton's toe. First of all, we would take a look if the second toe was longer than the first. The first toe is always supposed to be the most prevalent. So when the second toe is longer, we know to check the metatarsal heads. If they're in alignment, then we know it's not. It's just a longer toe bone. If they're not in alignment, we know it's a Morton's toe. And this is going to cause a severe Morton's neuroma, which is the pinch in that between those metatarsal heads. So you can see in the diagram there where the nerve has been inflamed, and it certainly puts an awful lot of pressure on that nerve once those heads have dropped, and therefore going to cause that inflammation. They can develop the Morton's neuroma in between any of the web spaces. However, it's more common between the third and fourth web space because there's two nerves running there as opposed to one. So that's why they typically feel it there first. And metatarsalgia, we discussed, it's the dropping of those met heads. Again, quite often it's because of bad footwear and pes cavus feet. So recommended questions that we would want you to ask your client to help you determine if they're having a foot problem insofar as gait and the way they're walking would be their pain level. So we like to identify what type of pain level they're in and they have and how often, when it happens. First thing in the morning is usually a typical indication that it's plantar fasciitis. Why? Because that tendon is healing overnight. We're a medical marvel. We're mending as we sleep. Get up in the morning, take those first few steps. That's when we're re-tearing everything. That's why it hurts more. History of orthotics. Have they ever worn foot support? Really good question to ask. Activity levels. How often they're on their feet. What are they walking on? What are they working on? All these things contribute to the way we walk. Any fractures and certainly any surgeries. If we've had any surgeries, it can also have a long-lasting effect on the way we walk. So those would just be a summation of the recommended questions that we would look for when we're seeing somebody for this type of appointment. But we would also ask them why they came to see us. You know, were they referred, or is it because they are in pain? So a lot of times that's going to give you the information that you need in order to be able to assess them properly. We would also do a full foot examination by removing their shoes and socks and exposing the ankles. We want to inspect the condition of the shoes, and we would want to check for any kind of wear on those shoes. We would also check for foot abnormalities and deviations, also discoloration, which I know you do on a regular basis, looking for hair growth, and the presence and condition of all the nails. So all of that is telling us a story as so far as how they're walking and how they take care of their feet. But one of the things I wanted to show you with a really good shoe is how to check a good shoe. So one of the things that I like you to do is pick up that shoe, turn it upside down, grab hold of that shoe and do a bend test. I want you to try and bend that shoe in the middle. If it does not bend at the arch of the shoe, that's showing you that it has good support. If that shoe folds up in half at the arch of the shoe, which is right there, then it has no support and they need a better footwear. One of the companies that I use in my practice is ASICS. However, there are many. New Balance is one of them that have or produce footwear that does not bend in the middle. So these are things that I think are essential in helping people understand that the footwear makes a huge difference. The other thing that we look for is the heel counter. So we don't want it folding in at the back of the shoe. We want that pretty solid to hug their heel bone as they walk. The other thing I like to show you is a different way to lace up the shoe, which is under proper footwear. So I undo the top eyelet. I take it out of the hole. I hope you can see this. I cross over and I come in through that hole from the outside in. So backwards to the way Mom taught us. You see the loop that it makes out front when you do that. You come outside in and it's making this loop. Pull that lace through the loop. So now when you tighten it, instead of pulling up to tighten it, you pull across. And that forces the shoe to grip the ankle, giving the patient better support. It also forces the foot to stay in the back of the shoe and not allow the foot to slide forward. When the foot slides forward, it leaves a gap back here. If there's a gap back there, they can rub up and down. If the foot rubs up and down, they develop the Hageland's bump. So we have to keep the foot in the back of the shoe, secure, so it doesn't slide up and down or forward. And that lace-up system is one of a key way to do that. When you go from outside in on both sides and you come back through that loop and you're now pulling side to side to tighten it, you can even tuck the laces. So the young teenage boys think that's very cool because they don't like bows. So they can tuck the lace and be very cool because this will not wiggle loose, which is another bonus factor for your seniors. How many seniors complain that their shoelaces come undone halfway in their walk and they got no place to bend over or tie it up? So this ensures that it doesn't wiggle loose or untie. Obviously, I would bow it for my seniors, but it's not necessary. To loosen the shoe, all you have to do is loosen what I tightened. And you're out of the shoe. So again, you don't have to relace it. You just loosen it off. And then when you come back and put your foot in, you grab the lace and you pull side to side and it tightens. So a very nice, easy way to help someone be more secure in their footwear. Obviously, if they're presenting with certain conditions, stretching and exercising is going to make a big difference to help them out of pain. And also the bits and pieces that I've shown you today will also help to bring them out of pain. So one of the things that we do expand on in our full-length course, which is a 4-day course, is the proper footwear and all of the props that we use on the foot. We also go through how to do a full analysis and a gait assessment. So we do work much more individually on gait and how to read that gait. And we also work on how to assess what kind of pain they're in, what's troubling them, and therefore gives us an idea of how to help them get them out of pain. So anybody that I think is interested in expanding their business to include a bit of this, it certainly helps separate you from a standard pedicurist in a salon. So I hope that gives you a good appreciation for why gait affects what you're seeing on the feet, corns, calluses, due to the pressure we put and incorrect weight distribution. So thank you very much for your time and attention. I know I've run over a little bit, so I appreciate your patience. And if there's any questions, I think Vicki will be able to field them for you now.
Hi, yes. Oh, Cindy, what an amazing presentation and so informative. Wow, that is a lot of information to cover in a short time frame. I will take a couple of questions. I don't want to spend too long taking questions. So while everyone's kind of typing in their questions, we do know that if you go to the NASP website, we do have our comprehensive foot and leg evaluations classes listed. However, due to the wonderful state of the world and COVID, borders are still closed. So Cindy is not going to be able to travel down to the US to teach our Orlando class. But stay tuned. We're going to put something together. We're going to put something together online where, we're going to videotape Cindy doing assessments and everything. So, stay tuned. Your best bet for interest in this class is send an email to nasp@kvg group or nasp@podology.net. I'm going to type that down in the question box so that everybody has it. But I think for the most part, if you guys just go to the contacts that I've been sending out to you, you will have our email there as well. Right now, I don't have any questions coming in right now, but if you guys do have questions a little bit down the road or anything, don't hesitate to let us know. Just give me a moment.